Good night, everyone, and welcome back to our OCMO weekly Wednesday gynecology didactics. And tonight is the second day and the last day of our gestational trophoblastic disease module. Last week, we have an overview of management of gestational trophoblastic diseases with Dr. Muhammad Anwar. And tonight, we have really the honor to have one of the most eminent new stars, rising stars in the pathology, in the world of gynae pathology and surgical oncology pathology in Egypt, Dr.Dina ElSamman. More or less, she is now very well known for most of surgical oncologists and gynecologists in Egypt and even pathologists. Dina is very active in delivering educational material and in delivering a very high standard presentations and high quality presentations about pathology, and is real an addition for all the teams that work with her. Dr. Dina ElSamman is lecturer and consultant of pathology from Ain Shams University. Welcome, Dina, and the floor of yours, and thank you for your time. She's going to speak tonight about gestational trophoblastic disease, and for our 50 participants, if you have any questions, just write it in the Q&A box, or you can discuss it after Dina finish, and thank you.
Good evening, Dr. Basil. Good evening, everyone. This is me, Dina, as Dr. Basil has introduced me, and I thank you so much for the super presentation. I'll be talking tonight about actually the pathology of gestational trophoblastic disease. But first of all, let me express my deepest gratitude to my dearest Dr. Basil Rif'i. Actually, Dr. Basil has gotten, and besides being a super surgeon, I'm not going to talk about this, of course, but he has got an aura and a positive energy that makes everybody around want to work with him. So I'm always pleased to meet him in any scientific meeting, and I'm extremely happy I'm with you all tonight. Okay, so after a very long day of surgeries, as I learned from him, I want to tell you, please hold on. This is you. You struggle at the first and you enjoy your life, hopefully, at the end. I'll be talking today about the gestational trophoblastic diseases. The WHO, the 5th edition, actually classifies the GTDs into 4 classes. The molar pregnancy, including the complete, the partial, and the invasive moles, the non-neoplastic lesions, including exaggerated placentacytes and placental-site nodule plaque, the GTN, or the neoplasms, including the choriocarcinomas, epithelioid trophoblastic tumor, placental-site trophoblastic tumor, and mixed trophoblastic tumors. And finally, abnormal and non-molar villus lesions. Okay. But first, let me ask actually 2 questions. Why do we call these gestational, and why do we call them trophoblastic? Firstly, we call them gestational because they are either themselves, they are considered as gestation or as if gestation, or because they are preceded by gestational event. So what's gestation? I believe you know better than me that gestational might be a pregnancy that can be normal, that can be ectopic, that can be an abortus that is either spontaneous or induced, and it can be a molar pregnancy. This is something that we're going to be talking about in a while, okay? Now, why are they called trophoblastic? Let me take you through a quick journey back like 20 years, maybe a little more, maybe a little less. When we were all in the womb of our mommies or in the uterus, we were this embryoblast and embryocyst. We had the cells that are called the trophoblast. Can you remember this trophoblastic layer? We studied it earlier.
الصوت
Actually,
بيبعد احيانا هنا شويه دينا.
Sorry.
الصوت بيبعد احيانا شويه، ما اعرفش يعني.
أيوة.
المايك you need to be close to the mic, please.
Okay.
Be close
I
to
will
your
do
mic.
my best. كده تمام؟ طيب كده تمام ولا إيه؟ كده كويس؟
كده تمام، كده جميل.
Is
clear.
this okay?
Yes, thank you.
Okay. Okay, so I was talking about the trophoblasts. Those trophoblasts are actually the cells derived from the fetus that contribute in the formation of the chorionic villi. This is the chorionic villi are actually the parts that invade the decidua of the mother to form the placenta. The placenta is the actual relationship of exchange between the fetus and the mother. Okay, so what are these trophoblasts actually? They are a group of cells. We have 3 well-known types of trophoblasts: the cytotrophoblasts, the syncytial trophoblasts, and the intermediate trophoblasts. We consider the cytotrophoblasts as the stem cells. These are the ones that are capable of differentiating into syncytial or intermediate trophoblasts. Actually, do not secrete any hormones, so they do not take most of the immunohistochemistry used except for cytokeratins. However, they have a high proliferative power as they are stem cells, as I have just mentioned. So we can use this information to be detected by a very well-known proliferative marker or immunohistochemical marker, which is the Ki-67. So they have a good proliferative power. The syncytial trophoblasts are actually the multinucleated cells. You probably remember something about them from the studying years, okay? These are the cells that secrete the placental hormones. They are responsible for the exchange between the fetus and the mother of the nutrients and everything. They do not have to be proliferative, so the Ki-67 is probably negative in which. The third type is the intermediate trophoblast, which is actually partial in morphology and functional resemblance to the previous two types, and it is classified furtherly according to location into villus implantation site and chorionic intermediate trophoblasts with different immunohistochemical expressions in Ki-67. This is the chorionic villus. Okay, as you can see, here are the fetal blood vessels. It's lined by cytotrophoblasts as an inner layer and a syncytial trophoblast an outer layer. Those cells that are trying to invade this decidua are actually the intermediate trophoblasts or the extravillus trophoblasts trying to start remodeling the maternal vessels. Now, why are you telling us all these histological details? Is there any clinical application for what you have just mentioned? Yes, for sure. Because all the types of the GTDs I'll be talking about today originate from those trophoblasts. Actually, each and every one originates from a certain type of a trophoblast. So what? How can we benefit from this actually clinically? If we know the immunohistochemical marker that each one of these trophoblasts express, we can use this in diagnosis, okay, in diagnostics. For example, the chorionic intermediate trophoblasts are the one that arise in the chorion levy. They express immunohistochemical marker that is called P63. So if I have a GTD that arises from those, I will use the P63. Another example, implantation site intermediate trophoblasts, they express the HPL and the MELCAM. So if I have a GTD that arises from those types, I will using those markers, etc. The syncytial trophoblasts, the HCG, and etc. Okay, now what about the molecular? Okay, again, the molecular diagnostics actually worldwide now has a very massive impact. If I know where do these diseases again arise from which cell and the combination of which cell, this will help me in the diagnostics, and I'll be talking about this now. Okay, we'll begin with the first class, which is the molar pregnancy. But before we dig deep into the cases, let me set with you some basics. So, what about pregnancy? What are the choices or the incidences or the probabilities of pregnancy generally? Okay, we have if we have the normal pregnancy, if we have a sperm that carrying the paternal genome that fertilizes a normal ovum with a maternal genome, and then we have a biparental diploidy. Diploidy means two sets of chromosomes, and biparental means from both parents. And this is what happens actually in normal pregnancy. Okay, so what happens in other cases? We have something that we call a partial mole. See what happens in a partial mole? Actually, when two sperms fertilize a single ovum with a single maternal chromosome, set of chromosome, we have three sets of chromosomes that we call triploidy. The two of which are paternal, we call diandric triploidy. This gives a partial mole. This is one case scenario for partial mole. Another case scenario is one sperm fertilizing and then duplicating again to give a triploidy that is diandric with two copies of genomes from a father. Okay, some publications are talking about triandric tetraploidy. These are three sperms, or maybe a sperm that is duplicating with another one and giving again a partial mole. The third case scenario that we have happens with complete mole when we have two sperms fertilizing an ovum that either has lost the maternal DNA before fertilization or after and results in diploidy, two sets of chromosomes, but both are actually from a male. We call this diandric diploidy. Diandric means both from the male. Okay, this is a complete mole.
Another scenario, if we have a single sperm that fertilizes an ovum, again, that has lost the maternal DNA, the maternal genome, and this sperm duplicates to give me again another diandric diploidy. The third case scenario is when we have a sperm fertilizing an ovum. Both the genetic material are existent, but there is one of those genetic mutations in one of those genes, the NLRP7 or the KHDC3L mutations. Those genes, actually, it's as if they turn off the maternal genome and prevent its expression. So it's as if it's non-existence. This one actually is rare and inherited, but should have been told. Okay. The last case scenario is actually not a molar pregnancy, but I thought I'd better put it here because it's one of the important differential diagnoses. That's when we have two sets of maternal chromosome and one set of paternal chromosome. That's again a triploidy, but this time it's digynic monoandric. I hope you now can imagine how things go in a transverse way. Okay, so we'll be discussing the today in a part of case scenarios. So case number one, we have a 33-year-old woman. She complains of 11 weeks of amenorrhea. Actually, she didn't complain. She was very happy at the beginning because she had that
Dina,
pregnancy test
you
and
have
she
gone
had
away from
that.
the mic too. Dina, you have gone away from the mic again.
Okay,
And please try just to
again.
speak slightly slower. Can you, please?
Yes, I can, but
Just
I'm afraid that the
try to
time
be
is
slightly
running
slower.
from me. Okay, I will
اوكي
do my
وقربي بس
best.
قربي من المايك عشان الصوت بتاعك. يس.
حاضر كده اهو. This is better.
يعني لو في better كان عن كده يبقى افضل.
لو في better, I don't know what's
او
the
ممكن يبقى
problem
المشكله عندنا
also.
احنا في المايك عندنا في القاعه، يعني مش عارف لو حد اونلاين يقول لنا.
Okay, can
لو
anybody tell
الصوت
us
واضح بس
online?
يعني try just to be slower for our Egyptian
Okay,
attendees.
I will, but give me 10 more minutes at the end, okay?
All
Okay,
the time is good.
anyone in the chat box, please tell us, is the voice okay or it's far away? Hello? Okay, I will try to raise my voice. Hopefully somebody replies to us. Okay, Dr. Basil. So I said I would be going through the different diagnoses of GTDs now in the form of cases.
Yes,
We have actually
they are saying Dina that the voice is far. انا اعتقد في مشكله في المايك، لو انت ممكن تفصلي المايك وتتكلمي اورالي على طول، يعني احيانا بيبقى
ما
صوتك.
هو انا بتكلم
ايوه
اورالي
كده حلو قوي. This is عظيم.
بجد كده
لا نو من دقيقه كان احسن.
كده
Yes now this is perfect now.
كده احسن حاجة.
لا كان من دقيقه احسن.
طيب معلش بقى
Yes
انا
this ده دلوقتي دلوقتي بتتكلمي ازاي؟
انا بتكلم
بس هو
ازاي
كده
انا
كده واضح بقى، كده واضح.
كده احسن حاجة فعلا.
اه انت داخله من جهازين او حاجه.
يس انا عامله كده. طب فيها ايه
ما هو واضح ان في
انا
واحد صوته
داخله من
فار
جهازين. انا عامله بس ايه سوري.
يعني في واحد
حضرتك قولي
واحد
اكتر. في
اتكلمي كده.
ايكو ولا في ايكو؟ طب خليني
مفيش
ممكن
ايكو
ناخد
مفيش
بريك
ايكو
دقيقه اجرب حاجه.
مفيش ايكو، هو في جهاز صوته كويس وجهاز صوته وحش.
لا انا مش داخله من جهازين. انا فاتحه سكرين تاني عشان اشوف فيها الشات.
بس دلوقتي احنا كويسين خالص.
اوكي دلوقتي كويسين.
وبيروح يبعد تاني معرفش ليه.
انا برضه مش عارفه فين المشكله بصراحه. طب هو ممكن حضرتك تديني دقيقة واحدة بس
اوكي
يعني أطلع المايك طيب لو في حاجة.
اوكي.
ماشي 1 minute.
كل سنة وانت طيب وسنة سعيدة عليك.
We are sorry for this interruption, but Dr. Dina is trying to fix the voice because it was so far. Dina? So again, we are sorry, everyone. Just Dr. Dina is trying to fix the voice. And we have
to detect. اوكي. طب ثانية واحدة بس بوطي صوتك عشان
بقى نسمعك يا دينا تاني كده.
المايك مايكروفون بعدين صوت ازاي عملت الميكروفون اكسس.
ماشي، لا مش اكسس، في اوبشنز في عندك ميكروفون.
ميكروفون privacy settings. مش انا بختار من الديسكتوب برضه؟
ممكن من الديسكتوب وممكن تخش على الساوند، تخش سيتنج، الكنترول بانل سيتنج.
ده كتير قوي بصراحة.
يعني طيب ما هو تاني سخيف.
كريم ثانية واحدة بس عشان الصوت طالع. اوكي ثانية. كنترول بانل. كنترول بانل ده اجيب منين؟ تاسك بار سيتنج، تاسك مانجر، تاسك بار مانجر. اوكي فين السيتنجز؟ مش عارفة يكون صعب اوي. فين السيتنجز؟ settings اها.
تلاقي ساوند على الجنب.
Bluetooth devices.
في ساوند سيستم.
view all
انا بقول لك على الشباك بتاع الويندو.
ماشي انا دخلت اهو.
تلاقي ساوند مع سجل، تلاقي وشك على طول.
لا خلاص مش لاقيه. لا
ارجعي تاني.
اللي هو كأن سماعة كده.
مش سماعه، ده جوه الويندوز علامه الويندوز 44 لما بتدوسي على الجبل يعني تفتحي الابس كلها. عشان كده
اوكي دكتور باسل.
Yes, now very clear.
بجد؟ طيب.
والله اشكر لنا كريم.
كريم thank you so much. انت طالع على فكرة. اوكي باي باي من الشيفت. باي باي. اوكي ثانية واحدة بس. Okay, I go ahead.
Yes, now the voice is clear. Thank you.
Okay, you are welcome. Okay, so back again. We agreed we will go through 7 cases quick, and Dr. Bessel will give us 10 more minutes or 15 more minutes at the end. Okay, so case number 1. We have a 33-year-old woman. She has 11 weeks amenorrhea. She did the pregnancy test, and it gave her 2 nice pink colors, so she thought she was pregnant, but unfortunately she had vaginal bleeding. So she went to her obstetrician, and he ordered the beta HCG. Actually, it was
massive. It's like 250K MIU per milli. Then she had the ultrasound, and you can see what there is on ultrasound. Actually, the obstetricians or the sonographers call this the snowstorm appearance. There's no fetal pole, no fetal parts, no fetal heartbeat for sure. So they had to take her the decision of dilatation and evacuation, and this is what we had as an evacuate. Okay. This evacuate we received in the pathology lab. It looked like this. We had those villi that were hydropic and dilated with some trophoblastic proliferations, actually, so that are circumferential. Actually, the whole slide looked like this. Then we had a new kit of P57 immunohistochemistry. We thought, why don't we try it? So we stained the slide, and we had actually negative P57 in the cytotrophoblasts and in the stromal cells, except for the positive internal control. Somebody from the molecular department was passing and suggested, why don't we do short tandem sequencing repeats? We said, okay. So we had a paternal dispermic diploid. Now my question, what are we supposed to be thinking of, or what did you suspect? Okay, so yes, this is a complete hydatidiform mole. First, let me tell you that hydatidi or hydatase in Greek means water drop, as we have seen in the gross picture. The vesicles of the mole look like grapes or water drops, and mole means false conception. And yes, this is true. This is not actual conception. This is false conception. Okay. Before digging more into details, let me tell you there is the European Organization of Treatment of the Trophoblastic Diseases that is actually endorsed by the ESGO, and they have a very nice diagnostic pathway algo for the hydatidiform mole. We did like actually most of the things in the case. You will have to revise the minimal requirements and their best practice requirements when dealing with such case. You have to do the cross matching and the blood, the NTD, the other things rather than what we have mentioned. And don't forget for sure the pathology or the histology. Okay, now somebody wants to know more about complete mole, and I'm ready for this. The complete mole actually is considered an abnormal gestation comprised of diffuse trophoblastic proliferation. Thanks God, we now all remember what are trophoblasts and what trophoblastic proliferation means. Proliferation means division of those trophoblastic cells that we all revise at the end of at the beginning of the talk. It also is characterized by the presence of villi that are enlarged with water. We call this hydrops that are diffuse. Very characteristic that we never ever find embryonic development with this. The genetic imprint is actually paternal only. We have an only paternal genome androgenetic diploidy, again, as we have mentioned. What about the epidemiology and risk factors of hydatidiform moles generally? Actually, there is actually location preferences. They're more common in the Southeastern Asia, the Middle East, and South America, rather than the Western Europe and the North America. Risk factors include extremes of maternal age less than 20, more than 40, but this is only for complete mole, not the partial. The history of prior mole is another risk factor, and the presence of genetics or recurrence may be in the bipaternal complete mole. Would only my patient become complaining of vaginal bleeding? No, actually, you can detect this case where she's asymptomatic. This actually occurs with the cases that go for routine first trimester ultrasound. They can be diagnosed earlier. يعني despite the fact that the signs wouldn't be as clear as the later on signs, but this can be detected, okay? She might have vaginal bleeding, excessive uterine size, hyperemesis, ovarian theca, lutein cysts, hyperthyroidism, even preeclampsia, owing to the very high levels of the beta HCG in this patient. This is the same ultrasound that we have seen in the case that the snowstorm is due to the many hydropic vesicles. And again, this is the pathogenesis I have said before, how a single sperm can fertilize an ovum that has lost the maternal DNA or the genome prior to fertilization or after to fertilization, and then duplicates to give us a monosperm
spermic complete mold. They call this homozygous because it comes from a single sperm that has duplicated. Again, this was the majority. The other case scenario that we have two sperms again that have fertilized ovum that is devoid of maternal DNA, lost before or lost after, to give us a dispermic, but this time is heterozygous because it comes from two different sperms, okay? And the last case scenario that we have said, when we have a single sperm and a single ovum, they are both existent. So this is a diploid, and it's biparental because it comes from both parents. Actually, this is extremely rare. The gross picture at the very beginning might look like only products of conception, just some fragments and blood, but later on it may look like these, okay? These are, you can see they look like grapes or water drops. These are for sure extended in saline, and that's why they look so beautiful, okay? So this is what the complete mold is supposed to look like. And we agreed that we never ever have fetal parts except in one condition. Can anyone tell me when can I see a complete mold with fetal parts? Has anybody seen this before? Hello, Dr. Basil. Will you ask them, please?
Dr. Naveen Tahun is raising her hand, and I'll allow her
Please,
to.
Dr.
She's allowed to talk. Dr. Naveen, go on.
Twin pregnancy.
Thank you so much. Thank you so much, Dr. Ravine. Yes, this is the only exception if the patient is or was pregnant in actually a twin, one of which was a normal pregnancy and then ended in abortion, and the second one was a complete mold. This would be actually some sort of a differential diagnosis for us. We would be asking ourselves, is this a complete mold and a twin or a partial mold? And I'll tell you how we're gonna differentiate between them. Thank you, Dr. Naveen. Okay, so microscopically, what are we supposed to see? We're supposed to see those villi that are hydropically enlarged, full of water, with frequent cisterns. If there is any pathologist attending with us, cisterns is this pale area in the middle. Those are supposed to be avascular without any blood vessels because there no fetal differentiation actually. We have circumferential trophoblastic proliferation. That's proliferation of the trophoblasts.
الصوت بيبعد يا دينا برضو احيانا للاسف، مش عارف ليه.
حظي سيء. اوكي. يعني اوكي هقرب من المايك اكتر. اوكي. Sometimes there is atypia, significant atypia.
لا احنا كده it's far away، يعني ما اعرفش. لا لو العيب عندي او دكتوره نيفين تقول لنا، حتى لو العيب عندي. دكتوره نيفين
هو فعلا بيبعد
بيبعد
for some
قوي.
reason يعني، بس it's okay يعني. we can hear you دينا.
انا كنت عايزه اجرب المايك اصلا and it didn't.
كان عندك اقتراح ما نستعملش مايك خالص، لو في اوبشن ما نستعملش مايك خالص ممكن يبقى الصوت اوضح.
انا كده مش بستخدم مايك اصلا، يعني انا كنت عايزه استخدم مايك.
ايوه هو دلوقتي يعني بيبان احيانا دلوقتي واضح تماما، وشويه بيروح وشويه بيجي. بس خلاص بدل الاتنديز شكلهم اغلبهم باثولوجيست النهارده متحمسين جدا، فايه جو اون.
اوكي اوكي طيب. بسم الله الرحمن الرحيم. I hope the voice gets clearer. Okay, so again, we said we have no fetal parts and no non-villous placental parts, okay? The syncytial trophoblasts actually sometimes they make something that is called medusa-like. It's like a crown. Again, let me be so much frank with you that things are not always so good. They are not always so clear, especially if it's very early. The villi may not be enlarged or not look the classic picture that I have just saying. Things will be different, and that's when we will need the P57 immunohistochemistry. That's a very nice immunohistochemical stain that we can use to detect whether we have a complete mole or something else, okay? In the complete mold, the P57 will be absent in cytotrophoblasts, okay? These are the cells lining the villi, and the villa stromal cells, the stromal cells in between, okay? This actually will be lost or absent or negative in both sporadic and familial biparental complete mold. Now, let me tell you some one more thing about the P57 immunohistochemistry, because it's really a good marker that we can use. The P57 is a marker that is paternally imprinted but maternally expressed. And this means that the gene is inherited through the paternal genome, but they cannot be expressed without maternal genomes. In case of complete mole, we have paternal only, and we do not have any maternal genomes, so the gene will not be expressed and the protein will not be found, and the immunohistochemical stain would be lost or negative. Okay. Can you hear me? Okay, so this is a nice algo of how to follow on using P57 and cytogenetics at the same time.
لا الصوت كده راح خالص يا دينا.
اوكي كده تمام.
هو يعني unfortunately it is so far.
اوكي طيب معلش انا اسفه جدا، هعمل محاوله ثانيه اخيره، ثانيه واحده. اوكي 1 minute again 1 minute break.
مفيش مشكله. بس هو ايا كان انت لازم هتريكورد البرزنتيشن دي وتبعتها لنا تاني ريكوردد، لان هي is very precious and valuable والصوت كتير كان بعيد، فاحنا كده كده محتاجه متسجله تاني. دينا انت رحتي فين؟ We are so sorry everyone for this technical problems. We are waiting Dr. Dina to come back. دينا انت سامعانا؟ عمرو اخبارك ايه؟
الماوس اتجاه معين
وانا مش عارفه ارجع الاسيستنت العادي ده.
وكده الصوت حلو يا دينا.
يعني مش فاهم يعني فين يعني مش عارف ايه العيله عادي عشان ما عملناش حاجه
ايوه يا دكتور. ايوه. Can you hear me?
يس.
طيب مش عارفة أقفل اللابتوب التاني، أنا اتأخرت عليكم بس I'm feeling so unlucky بصراحة.
معلش
آه،
يعني معلش احنا هنحتاجها منك ريكوردد بعد كده بالتفصيل تاني.
I can record it on my own بس خلينا طيب نسمع. طيب بسم الله الرحمن الرحيم.
Now the voice is clear. We hope it will be clear till the end like this.
Okay. Okay. بسم الله الرحمن الرحيم. Is it clear now?
Crystal clear.
Okay. Okay, again, I was talking about, I'm sorry for the interruption, everyone. I don't know why the things get so unlucky, but I hope things get repaired now. Okay, so I was talking about the P57. That's an immunohistochemical stain that we can use for the differentiation between the complete mole and the other molar pregnancies that we are suspecting. And I've just said that the P57 is a genome that is paternally imprinted but maternally expressed, meaning that it is inherited in the paternal genome, but actually they cannot be expressed if we do not have maternal genome. And that's the case scenario in the complete mole. We have only paternal genome. So the gene is not expressed and the protein is not synthesized, and accordingly, the immunohistochemistry would be negative. Okay, and again, this is a nice algo of how to deal if you have a hydatiform mole that you are thinking what it might be. You can go for the P57 at first. If it's negative, this is probably a complete mole. If it's positive, according to the genotyping, this might be a diandric triploidy partial mole or a biparental diploidy that is non-molar. Okay, so what are the differential diagnoses? Actually, the complete mole versus the partial mole versus the hydropic abortus versus even the non-molar early gestation. These are all stuff that can become a differential diagnosis together. And how can I reach the precise diagnosis? Precise diagnosis is using the diagnostic molecular testing, the most accurate of which is the short tandem repeat genotyping. Okay, in case of complete mole, it will give us androgenetic only genome. That's paternal derived only genome. I know that only karyotyping is the thing that people can use nowadays, but actually the karyotyping would tell you the ploidy only. It will say if it's diploid or it's triploid or tetraploid, but it cannot tell you if it's a maternal or paternal or a biparent. Okay, so to wrap up things, the diagnostic criteria that are essential for the diagnosis of the complete mole are the well-developed criteria that we have said microscopically, together with the P57 if we have an early complete mole, and finally genotypic analysis. Okay, what about the prognosis? Complete mole unfortunately can result in what we call persistent GTD in 15 to 20%, can result more unfortunately in choriocarcinoma in 2 to 3%, and maybe a risk of recurrence in 1%. Okay, that was all about the complete mole. Case number 2,
We have a 28-year-old female, 14 weeks of amenorrhea. Again, she had this pregnancy test with those two nice pink. I will not say nice pink colors actually, because it appears that they are sometimes nice and sometimes they are disastrous, as you can see. Okay, so she came complaining again of vaginal bleeding, and you order her the beta HCG. She now has the 700 MIU per milli. This is versus the previous case. She had like more than 150. I remember they were 250 or something. Then we used the proben. So what she had in her womb or uterus, actually, again, she had those vesicles, partly snowstorm appearance, but she had this. Do you know what this is? You know better than me for sure. This might be fetal parts. Then the patient had a decision for a dilatation and evacuation, and we had those products of conception, this part and this tiny part. Okay, you can all tell that's a very small fetus, and these are the products of conception. But let me tell you that this is not the classic case scenario, because most of the time we get only this part, this irregular bloody tissue part, and we do not get the fetal part actually. Under the microscope, we saw two populations, we saw two populations of villi. Some were dilated and villus, others were hydropic, and others were small, atrophic, and fibrotic. And I will tell you what else we have seen in the microscopic section. And then we did the P57 IHC, and we found it to be retained or preserved in both the cytotrophoblasts, those cells at the periphery, and the stromal cells in between. Again, somebody was passing by from the molecular department, and they examined the specimen and told us after a couple of days or something, we have a diandric monogynic triploid, and we reached the diagnosis. So what do you suspect, or what were you supposed to be thinking of? Yes, I assume you are hearing me now. Okay. Yes, this is supposed to be a partial hydatidiform null. So again, you have the same algo or the same diagnostic pathway by the European Organization of Treatment of Trophoblastic Disease. Okay, this is for clinicians to go back to while trying to approach the diagnosis. So what is the partial mole? The partial mole is again an abnormal gestation that is characterized by trophoblastic proliferation and villus hydrops, but now the villus hydrops is only in part of the villi and it's not diffused like the complete mole. We have an embryonic development, okay, that we might see on ultrasound or no, and we might see on gross examination of the DNE or no. Okay, and what's most important is that the molecular imprint is diandric monogynic triploidy. Again, how would the patient come to your clinic and what she would be complaining of? Probably missed or incomplete abortion. The vaginal bleeding is definitely less than that of the complete mole. On the ultrasound, you can see some not very specific, and you might be lucky and see the fetus or the fetal parts. What about the beta HCG? It's not so much elevated like the complete mole. It's normal or mildly elevated. Okay, this is the pathogenesis that we have mentioned. What happens is that we have two sperm that fertilize the ovum at a time to have a triploid. This triploid is dispermic because it was fertilized by two sperms, or it might be monospermic if one, less commonly, if only one sperm fertilized and then it duplicated. Okay. Grossly, we will see this picture actually of hydropic vesicles, definitely less than those we have seen with the complete mole. Again, if we are lucky, we can see part of the gestational sac or fetal membranes, or even maybe a fetus with intrauterine gross restriction and retardation and malformation, the most common of which is the syndactyly. Okay, as you can see in this picture. What am I going to see under the microscope? As I told you in the case slide, we have two populations of villi. One is some of which are dilated and hydropic, and some of which are small and fibrotic with variable degrees of hydrops. The trophoblastic proliferation is below circumferential. Okay, it's more or less than that of the complete mole. It looks like those islands. There's irregularities on the outer surface. Can see system formation. I don't want to say so much details because I know that clinicians are not so much interested in that, but actually these are the important differences for us as pathologists, we can see fetal blood vessels and nucleated RBCs as there has been fetal parts formed. Okay, so what's the role of the P57? Now the P57 would be intact. We would have positive P57 in the cytotrophoblasts and in the stromal cells. Okay. I want to tell you what about the case of the twin. We have I've asked you while discussing the complete mold, what if we have a twin? How would the P57 help in this case? Actually, in partial mold, you will find the P57 preserved in all the cyto and in all the stromal cells in the villi in front of you. In case of a twin, you will see them preserved in the normal villi of the twin, and they will be lost in the complete mold because the complete mold is complete mold still. Okay, so again, what's the role of the diagnostic molecular in partial mold? It's really important. Will give us a diandric triploidy to reach the precise diagnosis. Again, we still have the same differential diagnoses, adding to them twin gestations, placental mesenchymal dysplasias, digynec triploidies, and trisomies for sure. And this is to wrap up things. We need morphological features, we need genotyping, and we need retained, that's desirable only P57. The genotyping is mandatory for definitive diagnosis. The prognosis is definitely better than that of the complete mold because the persistence, the choriocarcinoma, and the risk of recurrence are with less incidences. Now we come to case number 3. We have a 41-year-old woman presented 2 months after curettage of molar pregnancy. She had molar pregnancy already, and she had a curettage, and she still has vaginal bleeding, and she has acute abdomen, okay? We did the beta HCG, it was persistently high, and we did the ultrasound, we saw this. So what are you thinking of? What this patient might be complaining of? Yes, persistent mold. She probably has a persistent mold. So what's persistent mold? That's remaining molar tissue after original treatment, whether medication and curettage, with persistently elevated HCG, due to one cause of which either an invasive mole, and by invasive mole I mean that the mole is invading the myometrium or the uterine vessels now, or it's metastatic. Maybe the chorionic villi have reached areas that are beyond the uterine cavity, most commonly the vaginal wall or the pelvis, for example. These are both called persistent mole, and they are treated by chemotherapy. Okay, now we come to the second topic, that's abnormal non-molar villus lesions. I don't want to talk a lot in that, but I just want you to know that there are abnormal non-villus molar lesions that look like partial moles. They are most probably differentiated using genetic testing, because under the microscope they look the same. With the P57 immunohistochemistry, they give the same result. Okay, where we go for the third topic, that is the tumor-like trophoblastic lesions, and these are actually nice and important ones. We have two: the exaggerated placental site and the placental site nodule and plaque. The exaggerated placental site is actually a non-mass forming infiltrative lesion, so it's non-mass forming, and this is really important. We consider it as a physiologic process that regresses spontaneously. It's formed of implantation site intermediate trophoblast. The Ki67 is low and there's no mitosis. And as I told you, it is incidental. It might be asymptomatic or with mild vaginal bleeding. What's really important about this is that when you see it, just take care. This comes after recent pregnancy. If the patient doesn't have any history of a recent pregnancy, if the patient has a mass, if the patient has this looking with a destructive invasion, if the patient has Ki67 that is more than 10%, this all shall make you worry and consider that you might have a placenta site trophoblastic tumor. So again, you have implantation site intermediate trophoblasts with unusually striking proliferation and atypia. You can see how huge the nuclei are and how atypical the cells are. This shouldn't make you feel scared, okay? What should make you feel scared is no recent pregnancy, mass forming, destruction in the Ki67 more than 10%. Go and consider PSTT and report that to your clinician. Ask them to do further imaging, maybe to take a decision together. Okay. The other one is the placenta site nodule. on the placental side plaque. Okay, again, this is an incidental finding, may be associated with vaginal bleeding. It's benign, but it's grossly more or less well circumscribed with a size that is less than 5 millimeter. Okay, microscopically, it's formed this time of chorionic type intermediate trophoblasts. It's characterized by this pinkish material, call it eosinophilic extensively hyalinized matrix. It takes the P63 and the inhibin on the immunohistochemistry, and again, it has a low Ki67 less than 5%. Okay, what's queer and where's the surprise about this? Actually, there's a new term that is called the atypical placentocyte nodule. Okay, I told you that the placentocyte nodule, they have the atypical. What's the atypical placentocyte nodule? This is an entity that should be considered when we have a larger size that is more cellular. It has more mitosis and atypia. Again, and what's about this atypical placentocyte nodule? This is in itself is a precursor to epithelioid trophoblastic tumor. And now we finally come to the most important topic for you today, which is the gestational trophoblastic neoplasms, the GTN. Actually, you have four entities: the gestational choriocarcinoma, the epithelioid trophoblastic tumor, the placental side trophoblastic tumors, and the mixed trophoblastic tumors. Okay, so we go for case number 4. Are you still with me? Is the sound more clear now, or you lost hope and you cannot hear anything?
We are with you. Sometimes the voice is fading, but we are with you still.
Okay. So case 4, we have a 33-year-old woman presented with vaginal bleeding and hemoptysis. So see, vaginal bleeding and hemoptysis, this patient might come to you, or she might go for the chest internist. This case might present with intracranial bleeding and go for the neurologist or neurosurgeon. She might go to different clinics actually. Okay, so she's still 33 years old. She has a markedly elevated beta HCG. This is her ultrasound and the Doppler. You can see there's the heterogeneous mass with increased vascularity. Chest X-ray was ordered, and she had those nodules on the lung and those ones on the CT. On biopsy examination, or after actually more massive decision, we had this infiltrative destructive lesion that is formed of malignant cells with blood sinusoids in between. We did her the immunohistochemistry of the beta HCG, and it was diffusely positive. So what are we supposed to be thinking of? Yes, a gestational choriocarcinoma. So what is gestational choriocarcinoma? Gestational choriocarcinoma is actually the most common malignant GTN. It comprises of a triphasic population of cells, the villus in situ trophoblasts, the cytotrophoblasts, and the intermediate trophoblasts. It can be seen in the uterus or at ectopic or metastatic sites. Your patient is usually of the reproductive age, and she's probably complaining of vaginal bleeding or hemorrhage at ectopic or metastatic sites. The HCG is actually very elevated. One more thing is to point out or to shed the light on is that we have intraplacental choriocarcinoma. That's a variant of choriocarcinoma that can occur during pregnancy, actually at any trimester, but commonly presented in the third trimester. It's mostly asymptomatic and do not present until metastasis within the patient or rarely in the infant, and this is very surprising to me. Have any one of you seen a choriocarcinoma metastasizing to the infant? Okay. So what about the risk factors? We have the prior complete mole, advanced maternal age, and the race. Actually, 50% of choriocarcinomas come after complete mole, 25% come after spontaneous or induced abortion, 22.5% come after normal pregnancy, and 2.5% are preceded by ectopic pregnancy. Okay, since half of them are preceded by complete mole, so the majority are androgenetic XX. Grossly, the tumor is hemorrhagic, as you can see, single or multiple dark red masses with florid hemorrhage and necrosis, deep myometrial invasion, may be spotted with the risk of perforation. This is how the intraplacental choriocarcinoma might look like, the placenta. It might be actually inconspicuous macroscopically, can mimic a placental infarct or thrombus. So please, obstetricians, examine your placentas very well. If you have anything that is that you suspect, please send them for pathology. There they can examine them and take multiple sections with 5 mm intervals. Okay, they may appear with papillary or solid formations. Okay, so what am I going to see under the microscope? The choriocarcinoma is formed of infiltrative destructive solid aggregates of cytos, in situ, and intermediate trophoblasts. That's the biphasic or triphasic population of cells, actually, with definitely marked atypia and hemorrhage. You can see those vascular pools. Okay, they used to tell us the choriocarcinoma is formed of vascular pools, and they explain why the metastasis is very common in choriocarcinoma. You can see lymphovascular permeation where and no chorionic villi are detected. Somebody can tell me when can I see chorionic villi along with choriocarcinoma? Another exception? Yes, in an intraplacental choriocarcinoma, if it's intraplacental, we can see the transition between the benign and the malignant trophoblasts. Okay. So what about the immunohistochemistry? We have actually a long panel. The HCG would give a diffuse and strong expression, actually. Those trophoblastic markers, the HLA-G and the HSD3B1, were not so we don't use them a lot, but the HCG is the favorite one. What's really important is to do the Ki67. The Ki67 is the proliferative marker, would be typically high. Cytokatins would definitely be positive, but they are actually positive in all trophoblasts. Okay, so what are the differential diagnosis? They are the rest of the GTNs, okay? The non-gestational choriocarcinoma of germ cell origin. Let me tell you that you might be very unfortunate if you have the case with a non-gestational choriocarcinoma and it's metastasizing and reaching to the uterus. Because actually the gestational and the non-gestational, they look typical under the microscope and with the immunohistochemistry. The main difference would be actually the clinical presentation, the site of the tumor, the age of your patient, and finally the genetic analysis. Okay. Again, sometimes we have somatic carcinomas with trophoblastic differentiation, and this can the microscopic picture can help, and immunohistochemical distribution can help in determining which. And again, finally, the benign mimics. Okay, that's the genotyping and how much it's important in differentiating. So to cut things short, or to wrap things, the essential diagnostic criteria for choriocarcinoma is the characteristic biphasic pattern or the triphasic pattern of the mononuclear trophoblast together with the syncytial trophoblasts. What's really desirable is to use the immunohistochemistry and do the genotyping. Chemotherapy, you definitely know better than me how much excellent the responses and the cure rate is. And Dr. Ahmed last time has explained to us the risk stratification and how you're going to opt for the different regimens. Okay, now we come to case number 6, the one before the last. We have a 36-year-old gravida, 1 woman with prolonged menstrual period and increased volume, thickened endometrium. Okay, she had hysteroscopy, and on hysteroscopy you saw this mass. Her beta HCG was actually around 2000 MIU per milli, where we had the biopsy, and then she had a decision of hysterectomy, and this was the tumors. You can see that's more or less a monotonous tumor with moderate atypia and very demarcated cell membranes. Okay, we did the P63, it was positive. We did the Ki67, it was some sort of elevated. So what are we supposed to be thinking of? Yes, we're supposed to be thinking of an epithelioid trophoblastic tumor. Again, the European Organization of Treatment of Trophoblastic Disease has this algo for you. If you suspect an epithelioid trophoblastic tumor or a placenta-side trophoblastic tumor, these are the minimal requirements for you for the diagnosis, and these are the best practice. Including to contact the GTD center, and we'll be talking about this at the end of the lecture, actually. So what's the epithelioid trophoblastic tumor? That's the rarest GTN. It's formed of chorionic type intermediate trophoblasts. Remember when I told you that the type of intermediate trophoblast would have a clinical implication with the immune immunohistochemistry. I will tell you in a second. Okay, it can come in the uterus, the cervix, the fallopian tube, ovaries, or the peritoneum. Then presented with vaginal bleeding almost, but the HCG elevation is mild or moderate. Do not forget that the atypical placenta-site nodule is considered as a precursor lesion. Grossly, the tumor is invasive, may show discrete nodules or cystic hemorrhagic masses with a cut section that is tan to brown. This tumor tends to ulcerate and fistulize, okay? What about the microscopic picture? We have a well-circumscribed nodular mass with the trophoblasts that has nest cords and uniform cells with a pink material that we call the eosinophilic hyaline material that's very characteristic, and the necrotic geographic necrosis that's characteristic again. The mitosis that is variable, and the atypia is actually moderate, not like the choriocarcinoma. What about the IHC? We prefer to go for the P63. We have again a long panel that we can use. P63 is a really nice one. The Ki67 is again elevated, and as I told you, cytokeratin 5/6 may take the stain. That's the P63 positivity, and that's the Ki67 more than 10%. Okay, that's all we need for the diagnosis. What about the prognosis? We have 25 to 30% of these cases metastasize, 10 to 25% are fatal. The prognosis is worse when we have a higher mitotic count or antecedent pregnancy of 4 years. They can, okay. And the PDL1 has been detected to be highly expressed. Of course, we can take advantage of this, that some cases might show maybe a response to immune checkpoint inhibitor treatment. Okay. The last case, the case number 7, we have, are you okay? Are you listening to me? Okay. We have case number 7, 32-year-old female with amenorrhea and uterine enlargement. She had her beta HCG, it was around 700. That's called mild elevation. She had an ultrasound. She had an irregular contour of endometrial cavity together with a heterogeneous myometrial echo texture and hematometra. That's her uterus, and that's her microscopic picture. As you can see, we have a diffuse infiltrating tumor with atypia. We'll be seeing this. We did her the immunohistochemistry that was HCG focally positive, excluding a choriocarcinoma, and P63 negative, excluding an epithelioid trophoblastic tumor, and an HPL positive, so making us suspect more the placenta-site trophoblastic tumor. So what's the placenta-site trophoblastic tumor? Now that's the third GTN to talk about today. It's like a 4 to 5% incidence. It originates from implantation site intermediate trophoblasts, and again can come uterine or extrauterine less commonly. Actually the most common presentation would be a history of missed abortion and amenorrhea. Again, the patient's HCG elevation might be mild to moderate. Rarely, some patients come complaining of virilization, nephrotic syndrome, and erythrocytosis, and most of them are presented early as stage 1. The grossly, we have this well-circumscribed nodular mass involving the endomyometrium with probably deep myometrial invasion, hemorrhage, and necrosis. Perforation may occur. This is what we have seen in the first slide. We have this infiltrative aggregates in sheets of large polyhedral to round mononucleated cells. Multinucleated cells may be seen, but now that the atypia is marked, I bet the pathologist can spot it here easily versus the other one. We can see necrosis, okay, and myometrial infiltration. What about the immunohistochemistry? We have, again, a long panel. We can go for the HPL and the MELChem. They are both positive in this type of intermediate trophoblasts. We can go for the PDL1, but this is for therapeutic purposes rather than diagnostics, and most important of which we use the Ki67 to detect that it is a placenta-site trophoblastic tumor, not the benign counterpart. You can use the P63 and the HCG again to exclude the other differential diagnoses, as we have said. So what's really diagnostic is we have the invasive trophoblastic neoplasm with compatible immunoprofile. The simple hysterectomy is curative when it comes to prognosis. 30% may develop recurrence or mass, and the mortality rate is 6.7 to 27%. Now, what if we have a mixture? Can we have 2 or 3 of those tumors? Yes, we can have those in the same patient in the same context, and we call this mixed trophoblastic tumor. Okay, these are the immunohistochemical stains that we have mentioned before. I don't want to take you for long, but before I leave, you have more 5 minutes to talk about something that we call the trophogram. What's actually the trophogram? That's an immunohistochemical algorithm that was produced by Dr. Elming in 2007 to make things easier. Okay, so if you have a suspected trophoblastic tumor, you can use low molecular weight cytokeratin with a trophoblastic marker, that's the HSD3B1. If both are positive, then these are trophoblasts. If only the low molecular weight cytokeratin is positive, so this is an epithelial lesion, might be a carcinoma or something, but not a trophoblastic tumor. Okay, so what's the next step? Assuming that it's trophoblastic, you can do the beta HCG. If you have it positive within a mixed population, so this is a choriocarcinoma, you can go for the P63 and HPL. If you have a negative P63 and it's diffusely positive HPL, then this is an implantation site intermediate trophoblast related lesion. On the other hand, if we have the P63 diffusely positive with an HPL that is focal or negative, this is probably chorionic type intermediate trophoblast related lesion. How can we spot the benign versus the malignant counterpart using the Ki67? In the implantation site, variance to the Ki67 less than 1, this is an exaggerated placenta site. If more than 10%, this is a placenta site trophoblastic tumor. In the chorionic type suspected lesions, if you have the Ki67 less than 8%, preferably with a cyclin E negative, that's a placenta site nodulum plaque. If more than 10% with a cyclin E, that's an epithelioid trophoblastic tumor. Okay, to end things with, do not forget that we use the FIGO staging for staging of GTNs. We have those 4 stages that Dr. Ahmed told you about last time. Okay, some pathologists prefer to use the TNM staging. That's for the American Joint Cancer Committee. In GTNs, actually, we have the T and the M. We do not have the N. The T1 for confined to the uterus, and the T2 for the genital structures, the M1A for the lung mets, and the M1B all other distant mets. I know always that gynecologic oncologists and gynecologists prefer the FIGO over the TNM, but we have to tell you that we sometimes go for the TNM. Okay, again, the WHO has a prognostic risk scoring system that the clinicians use for assessing whether the case is low risk, high risk, or ultra high risk to set the treatment plan. And finally, I would love to tell you something about the EOTTD. I told you that's the European Organization of Treatment of Trophoblastic Diseases, and I was so excited to tell you about it as I learned that the ESGO supports the European organization, and you are an ESGO accredited center, so we had to mention this. Actually, the EOTTD has a very nice publication on the practical clinical guidelines for the treatment and referral of GTDs. What actually caught my attention at the end of the paper was their advocacy for the establishment of a national GTD center. They believed that the centralized care is needed for optimal management of rare disease like a GTD, and that without some type of centralization, treatment decisions will be inconsistent. Now, these are the steps for the national center setting. Okay, I will start by step number 1, which is sharing the idea and promoting for it. I will leave the rest of the steps to Dr. Basil actually to take action and then call me. The step number 2 would be the support from a national OBGYN governing body. The step number 3 would be making an MDT meeting. The step 4 would be to create or adopt clinical guideline, create a database, develop a website, and make a proper HCG assay system. Number 5, we would need an annual funding. And finally, we would need to establish connection with international societies like the EOTTD and the ISSTD. Thank you so much for holding on with me all this time. I really apologize on the technical thing. I promise you another clear record, inshallah. Finally, I would love always to put this slide to shed the light on the importance of teamwork. These were my references. This is my page. I call you to follow it. Thank you so much. And thank you so much, Dr. Basin, everyone. I hope this was a beneficial talk.
Thank you so much, Dina, really, It was a very interesting talk, despite of all the technical difficulties and the voiceover. So Dina, I don't believe that we have so much time because we are over time for discussion. But again, I'd request you to record this very important presentation, to record it, and I'll have it from you recorded to upload on the website page and the YouTube channel. I'll try to upload this one too, but I'm waiting for one which is recorded with a clear voice because the slides are great, everything is great, the approach was great, but we were unfortunate by those technical problems and the voice. If you are going to hear the recording, you will know that it was sometimes far away. By the way, we have a GTN clinic here in Mansour University, not in our center, but in the Obigani department, which was created by Professor Reda Shouki. He is one of the GTN pioneers all over Egypt, whom we all sent our condolences because he have just lost his daughter last night. So our deep condolences for him. But really, we have a GTT center in Mansoura, Obigani department, that they are doing centralization of care and they are doing very good job there. Thank you, everyone. We are so sorry for the technical difficulties. We are waiting for the recorded presentation from Dina, and see you next week with the start of the complications chapter. Thank you. Good night.
Thank you so much.